All right, so today we're going deep into locally advanced breast cancers. Stages 3A, 3B, and 3C.
Some pretty challenging cases for sure.
Absolutely. And things have evolved so much in how we manage them. I mean, think about it. Neoadjuvant chemotherapy has practically become the go-to first move for almost all these patients now.
Yeah, it's amazing how neoadjuvant chemo has transformed our approach.
Really is.
That initial tumor shrinkage we can often achieve is huge. It makes a world of difference when we get to surgery. Sometimes it even makes surgery possible when it wouldn't have been before.
Exactly. So let's say we started the neoadjuvant chemo.
Okay.
Now, as surgeons, we're always thinking ahead to the OR, right? But we need to know how that chemo is working. So how do we go about that early assessment? When do we check, and what exactly are we looking for?
Well, around 3 weeks after the second cycle of chemo, that's our cue to do a good clinical exam. Feel for any changes in the tumor size, consistency, that sort of thing.
Makes sense.
But to be really systematic and to communicate clearly with our colleagues, we use the RECIST criteria. It's kind of like our universal language for gauging response to treatment.
Ah, yes, RECIST. A good reminder for everyone out there. Could you quickly walk us through those key classifications again?
Of course. So we have a complete response, or CR. That means the tumor's essentially gone, no palpable mass, nothing showing up on imaging either. That's obviously what we're hoping for. Then there's partial response PR. That means the tumor has shrunk by at least 30% in its largest diameter.
Okay, so a decent reduction, but not completely gone.
Right. Then we have stable disease, or SD, meaning it hasn't shrunk enough to qualify as a PR, less than that 30% reduction.
And then, of course, there's the situation where the news isn't so good.
Yeah, unfortunately, there's also progressive disease PD. That's when the tumor has actually grown by at least 20% in its largest diameter. If we're seeing that, well, it tells us the chemo isn't effective.
Right. So we've done our assessment. We've got our RECIST category. Now, what's the next step in our surgical game plan? Does this response dictate how we proceed?
Absolutely. If it's a complete response or a partial response, we usually forge ahead with the full course of chemo that we initially planned. Got to maximize that initial benefit before we even think about going in surgically.
Makes sense. And thinking about those patients who respond well and might become eligible for breast-conserving surgery.
Yeah.
There's something super important we can't forget to do before they wrap up chemo.
Ah, you're talking about placing a marker.
Exactly.
It's a small step, but it can make a huge difference later on. For anyone who might be a candidate for BCS, we've got to place a radio-opaque clip, like a mag seed or another marker silicone, PVC catheter tip, something like that, right into the tumor bed.
So even if the tumor's barely visible or even completely gone on imaging, that marker acts as a guide.
Exactly. It's like leaving a trail of breadcrumbs. Make sure we can target the exact right spot during surgery and get that complete removal even months down the line.
Brilliant. Now, what about those times when the chemo doesn't give us that response we were hoping for? What do we do surgically if it's stable disease or, even worse, progressive disease?
In those cases, if the tumor just isn't budging with the chemo we've chosen, well, we usually move straight to surgery.
Makes sense.
No point in delaying if the current regimen isn't doing its job. And after surgery, we'll switch gears to a second-line chemo regimen to target any systemic disease that might be lurking.
Got it. So we've covered chemo, then that all-important RECIST assessment to figure out how things are going. Then, based on that assessment, either more chemo or on to surgery.
Right.
Once the neoadjuvant part is done, no matter how well the tumor responded, we then have to discuss the surgical options with the patient. So what should we be offering? What's on the table?
Well, after we finish that neoadjuvant chemo, breast-conserving surgery should always be an option for appropriate patients alongside mastectomy.
Of course, it's a joint decision, shared decision-making. Got to consider both what's safest from an oncologic standpoint and what the patient feels most comfortable with.
Absolutely. But it's super important to remember there are situations where breast conservation just isn't the best or safest route.
Definitely. So when are those situations?
Like if a patient initially comes in with T4 disease, so that's skin involvement or chest wall involvement, or with inflammatory breast cancer, a modified radical mastectomy, an MRM, is generally what we recommend. In these cases, trying to get clear margins and good local control with breast conservation surgery, it's often just not doable or safe from an oncologic perspective.
Let's shift gears now and talk about the axilla. Sentinel lymph node biopsy after neoadjuvant chemo. It feels like that's an area where our approach has been evolving.
Yeah, for sure. It's still evolving.
Lots of ongoing research as well.
Especially when it comes to patients who initially present as clinically node negative, that CT3 and 0 group, or those who convert to clinically node-negative after chemo, the accuracy and the best way to use sentinel lymph node biopsy, it's still something we're figuring out.
And we have to be aware that the accuracy of sentinel lymph node biopsy, or SLNB, after neoadjuvant chemo, it isn't quite as reliable as when we do it up front with surgery.
Right.
That whole issue of false negatives, it's a definite concern, isn't it?
Oh, absolutely. A big one. The reported false negative rates with SLNB after neoadjuvant chemo, they can be over 10%. And that's significant because a false negative could mean we understage the axilla and potentially don't get adequate regional control.
So how do we minimize that risk of false negatives when we're doing SLNB after neoadjuvant chemo? Any techniques or precautions we should be extra careful about?
There are a few key strategies. First off, we should always aim to take out at least 3 sentinel nodes. And using dual tracers, usually blue dye and a radiocolloid, it's definitely recommended to improve our chances of finding those nodes. Another thing that's becoming more common and really helpful is targeted SLNB.
Targeted SLNB. I think some of our listeners might not be as familiar with that. Could you break it down for us?
Sure, so let's say on imaging, before chemo, we see a suspicious lymph node in the axilla. We do an ultrasound-guided biopsy, and it comes back positive.
Okay.
We can then put a metal clip in that node or inject some permanent India ink. Then, when we operate after the chemo, we specifically look for and remove that marked node.
I see.
We do that in addition to the usual sentinel lymph node biopsy. The idea is, even if that marked node looks normal after chemo, we know it was involved before. So taking it out gives us valuable prognostic information. And it also makes sure we're not missing any disease that might be hanging around in there.
Makes a lot of sense. Okay, moving on to adjuvant therapy. So we've dealt with the main tumor and the regional lymph nodes. Next, we got to think about minimizing recurrence,
Absolutely.
both locally and in distant sites. And that's where adjuvant radiotherapy really comes in.
Couldn't agree more. It's a crucial part of the treatment plan. It really helps lower the risk of local and regional recurrence. And it definitely has a positive impact on overall survival for these patients. It's not something we take lightly.
For sure. So when it comes to adjuvant radiotherapy in this group of patients, are there any clear-cut indications?
Oh, definitely. Any patient with locally advanced disease, so that's T3 or T4 tumors, and any N1, N2, or N3 nodal involvement, they should all get radiotherapy. It's pretty straightforward. Plus, it's standard practice after breast-conserving surgery no matter what. And even after mastectomy, there are certain situations where we recommend it.
Like what kind of situations after a mastectomy?
So after mastectomy, we'd recommend irradiating the chest wall if the final pathology shows a tumor 5 centimeters or larger, if there was any sign of skin or chest wall involvement initially, or if we find lymphovascular invasion or LVI on the pathology report, also if it's a grade 3 tumor, and of course, if any axillary lymph nodes turn out to be positive.
So even if we've done a mastectomy, there's still quite a few scenarios where radiotherapy is part of the plan.
Yeah,
And the actual radiotherapy protocols themselves, they're not a one-size-fits-all kind of thing, are they? The approach depends on what kind of surgery we did and the nodal status.
You got it. For node-negative tumors after breast-conserving surgery, the standard is usually somewhere between 45 and 50.4 gray, given over 25 fractions to the whole breast. And we often add a boost to the tumor bed, just to be extra sure. We zap any microscopic disease that might be lingering there.
Okay.
There are also hypofractionated regimens. Those are gaining popularity now. Something like 40 to 42.5 gray in 15 or 16 fractions. So a slightly higher dose each day, but over a shorter period. It's a good option in a lot of cases.
And what about radiotherapy after mastectomy? What does that look like?
After mastectomy for a T3 Ender M0 case, we strongly consider chest wall radiotherapy, even if the sentinel nodes were negative. Remember, the tumor was big to begin with, so there's always that risk of local recurrence. Now, with node-positive disease, we're talking about locoregional radiotherapy.
What areas are usually included in that locoregional approach?
That usually covers the chest wall, the supraclavicular area, the internal mammary nodes, and the axilla. But, and this is crucial, we usually don't irradiate the axilla if we've already done a full axillary dissection.
Makes sense. Don't want to add to the risk of lymphedema if we don't have to.
Exactly. We've already cleared the area surgically, so radiation isn't usually necessary.
We should also touch on accelerated partial breast irradiation. What do we think about using that?
APBI is a good tool, but it's really reserved for specific low-risk situations. So, for example, women 50 or older, T1 invasive ductal carcinoma, nice clear margins of at least 2 millimeter, no lymphovascular invasion, ER positive, BRCA negative, and negative sentinel nodes. We might also consider it for low-risk DCIS, the kind that was picked up on screening, low or intermediate grade, 2.5 centimeters or smaller, and good margins of at least 3 millimeter. Those are the types of cases where it might be appropriate.
And the way we actually give APBI is pretty different from the usual whole breast radiation route.
Yeah, it's a lot more focused. We usually deliver the radiation straight to the tumor bed plus a small margin around it, and it's often given twice a day for 5 days. So the whole treatment course is much shorter.
All right. So far, we've covered local and regional control with surgery and radiation. Now let's think about those pesky micrometastases. That's where adjuvant systemic therapy steps in.
Exactly. The whole point is to catch and eliminate any tiny cancer cells that might have spread but that we can't see. We want to reduce the risk of distant recurrence and improve long-term survival. And chemo is still a really important part of that.
What are some of the common chemo regimens we use in the adjuvant setting for locally advanced breast cancer?
There are quite a few good options. CMF, which is cyclophosphamide, methotrexate, and 5-fluorouracil. That's a classic. We also use anthracycline-based regimens like CCAF and CEF. And then there are the taxane-based regimens, docetaxel and paclitaxel. Sometimes we use them one after another, or sometimes we combine them. It really depends on the case.
When we're thinking about using adjuvant chemo for our patients, what are the general guidelines?
So generally, any invasive tumor over 1 centimeter, we consider chemo. For smaller tumors between half a centimeter and 1 centimeter, we look for things that make it riskier, like LVI, high grade, HER2 positive, or triple negative. And of course, if there's any node involvement, no matter the tumor size, we usually recommend chemo.
Seems like there's a lot to consider when making the decision about chemo.
Definitely. It's not just about the size of the tumor. We have to look at the whole picture, the stage, the biology, the hormone receptor status, the HER2 status. It all plays a role. And we always discuss these cases at our tumor board meetings to get everyone's input. That way we can tailor the plan to each individual patient.
And those multi-gene assays like Oncotype DX, Precinia, and MammaPrint, they've become really helpful tools, haven't they?
Oh, incredibly helpful. They've really revolutionized things, especially for those lower risk, ER positive, HER2 negative, node negative patients. Those assays can help us figure out who really needs chemo and who probably won't benefit much from it. It's all about avoiding overtreatment whenever we can.
And what about the HER2 positive patients? They need a different approach, right?
Yeah, HER2 positive breast cancer is its own beast. For those patients, we usually combine chemo, usually a taxane and often an anthracycline, with targeted therapy. So that's trastuzumab and pertuzumab. That's become the standard of care. And then there's TDM1, or trastuzumab emtansine, which is an option for patients who still have disease after neoadjuvant treatment with trastuzumab. It's basically a way to deliver chemo directly to the HER2 positive cells.
And of course, we can't forget about endocrine therapy for hormone receptor positive cancers. What are the mainstays there?
So for premenopausal women with hormone receptor positive disease, tamoxifen is usually what we use. 5 years for lower risk cases, but we often go up to 10 years for higher risk situations like positive nodes, tumors over 5 centimeters, or LVI.
And for postmenopausal patients.
After menopause, we generally favor aromatase inhibitors over tamoxifen. Anastrozole, letrozole, exemestane, they've all been shown to improve disease-free survival and overall survival.
But we do have to keep an eye out for the side effects of aromatase inhibitors, right?
Definitely. Bone loss is a big one. We always get a baseline bone density scan before starting an AI. And we often recommend bisphosphonates along with vitamin D and calcium, not only to protect the bones, but there's some evidence it might even help reduce recurrence risk.
Once our patients have finished all their treatment, they move on to that long-term follow-up phase. What does our standard surveillance plan usually involve?
Long-term follow-up is absolutely key. We want to catch any recurrences early, whether local or distant. So our usual recommendation is a clinical exam every 3 months for the first 2 years, then every 6 months for the next 3 years, and then yearly after that.
And imaging is a big part of that surveillance too, right?
Absolutely. Everyone gets yearly mammograms. And for anyone with implants or a known BRCA mutation or another genetic risk factor, we usually also recommend a yearly breast MRI with contrast.
It's also important to make sure our patients are actively involved in their follow-up, don't you think?
Oh, for sure. We always emphasize how crucial it is to tell us about any new symptoms right away, even between scheduled appointments. Early detection of a recurrence can make a world of difference in terms of treatment options and outcomes. And obviously, if someone does have metastatic or recurrent disease, we'll need to follow them much more closely, tailoring the plan to their specific situation.
Well, that was quite a journey. We've really covered a lot of ground today.
Yeah, I think we've given a pretty good overview of the current strategies for managing locally advanced breast cancer, all based on those fundamental principles we learned from Bailey and Love. It's a complex field and it's constantly changing. But the bottom line is neoadjuvant chemo, careful response monitoring, tailored surgical techniques, individualized adjuvant therapies, and long-term surveillance. That's what's making a real difference for our patients.
It's incredible to see the progress we've made in treating locally advanced breast cancer.
I agree. It's inspiring.
Thanks for being here and sharing your expertise.
My pleasure.
Thank you for listening to our podcast. See you in the next episode.